Hi everyone, it's Dr. Hall, and we're going to get started with the first half of the lecture for Chapter 2, which is about evidence-based public health. So when we talk about evidence-based public health, that means we don't want to just be guessing. We want to have data and some rationale behind our conclusions and our recommendations. So we're going to talk about the process for that. So the book uses a nice little mnemonic, PERIE, P-E-R-I-E, which I think is useful to identify the 5 basic steps involved in the public health approach. So identifying the problem, discovering or trying to decipher the etiology or cause of the problem, coming up with some recommendations, figuring out how to implement those recommendations, and then evaluating what you're doing. So if that sounds a little familiar compared to when we talked about, introduction to public health, it should. So this is a really busy slide, and I created it because you can use it to review later. In the meantime, I just want to show you that this kind of identifying the problem and discovering the etiology or causes of the problem is basically that assessment step that we talked about before, identifying what is going on, what is the situation. Coming up with recommendations and figuring out how to implement them, well, that's the policy or what would work step. And then part of implementation and evaluation then is just like the assurance or is it working step. So this is just breaking that down even further into more individual steps. So let's take them on one by one. Problem, what is it? So we want to be really clear about what the problem is, and some of the ways that we describe problems in public health are in terms of its burden. So how much death and disability does it cause? Death would be your mortality, how many people actually die as a result of this condition. And disability is often referred to as morbidity. So how many people aren't able to live their lives as fully or as healthfully as they otherwise would because of this condition. And then we want to understand the course of the disease. Do you just have it for a short time? Do you have it for a long time? Kind of what goes on with it. And so there are 2 numbers that we look at to help understand the course of a disease. One is incidence, which tells us how many people get diagnosed with a condition over a period of time, usually 1 year. And the other is prevalence. So how likely is it to be present at any given time, right? So what percentage of the population is going to have this condition at one given time? And then of course, mortality is going to be important for understanding the course of a disease. So let's talk about incidence and prevalence in a little bit more detail. So incidence, again, what proportion of the population is diagnosed over a certain period of time? So an example would be how many people got infected with COVID this past year. And so what we're going to want to do is we're going to want to look at this as a rate, like how many people got diagnosed out of how many people are there total, not just the overall numbers of how many people got infected. And let me show you why. So this is a graph actually from last year, but it was pretty, so I kept it. And so what we can see here is cumulative confirmed case numbers of COVID-19 infection in different states. And you take a look at this and we've got, let's see, here's my laser pointer. So we've got California way up here, over 5 million, right? Wisconsin down here, around 1 million. So goodness, those Californians, right? They just must be spreading COVID all over the place. But actually, California is just a bigger state than we are. So of course they have more people who got infected. So if you control for the population, if you look at the rate rather than the total numbers, what you're going to see is this. So in this one, we're looking at cumulative cases, and it's usually out of every 100,000 people. That's usually the denominator they look at. And you can see that when we actually control for the population, when we look at the rate, the incidence rate, California was looking really good, and Wisconsin not so good. So a higher percentage of our population got infected with COVID-19 compared to California. So just make sure to always control for the whole number of the population at risk. So look at rate, not total numbers for incidence. Another incidence question we can ask is, what was the incidence of chlamydia infection, which is a sexually transmitted disease, in Dunn County in 2019? And this is publicly made available by our public health agencies in the state of Wisconsin, right? So collecting and analyzing data, you might remember, is one of those 10 essential functions of public health. And so you can actually get this information online. And in 2019, there were 155 total cases in Dunn County. Our population at that time, it's a bit higher now, was about 42,700. So what you're going to do is say, okay, so 155 cases out of 42,700 is equivalent to X, the incidence, out of 100,000, because again, we're often going to be looking at that per 100,000 people. Because if you use percentages, these are so low that it's like 0.0 something percent, and that's messy. So we like to look at out of 100,000 people. So if we do the math, we will find that that's 363 per 100,000 people in 1 year, which is about 1 in 275 people. But now you might remember from our earlier lecture as well that different risks appear at different stages of the lifespan. And so you might think to yourself, well, I'm thinking that maybe Dr. Hall, as someone who is 50, might be at a slightly different risk of contracting chlamydia than perhaps some of my students who are in their late teens and early 20s, for the most part, with exceptions. So let's take a look at the incidence within a specific age group in Dunn County, right? And we have that data too. So overall for the county, 1 in 275 people, or 363 out of 100,000. Let's take a look at young people. So incidence of chlamydia in young adults. There were in 2019 about 4,000 people ages 20 to 24. That's an age bracket that Dunn County happens to use. Again, as I've talked before, different agencies use different age brackets. It's infuriating. It makes life difficult, but this is what we have. And of those, 66 were diagnosed with chlamydia, right? So out of those total 155 cases, 66 were in people in this age group. So let's do the math. Right, so 66 out of 4,030 is equivalent to 1,636 out of 100,000. So that's actually 1 in 61. So it went from 1 in 275 for the overall population to 1 in 61 young adults. So it's pretty common, okay? So we see quite a lot of chlamydia in young adults in Dunn County. We see quite a lot of chlamydia in young adults in most of the entire country. It's just a really common infection. So that was incidence. Now let's talk about prevalence. So incidence was how many people got diagnosed. Now, in order to get diagnosed and officially counted as having the disease, you have to get tested, right? But now sometimes diseases or conditions don't have symptoms, as we all know. So chlamydia is one of those, for example. So this question is, at any given moment in time, how many people actually have the condition, whether they have known it or not, right? And so in order to do this, we're going to go out and sample a whole bunch of people, whether or not they have symptoms, all at a certain time. So let's take a look at an example of prevalence data from a different college campus from last year. So in December 2021, Cornell University tested all of their students, like all of them, all 30,000 students in 1 week to see how many of them had COVID-19. And so this is what we found. Okay, so depending on the day of the testing, right? But look, there was quite a lot of COVID going around. And so if we looked, so they tested a total of about 28,000 and 1,600 students tested positive. So the prevalence was 5.6%. So on any given day, approximately 1 in 18 students was positive for COVID. And as we know, a lot of those people didn't know it. They were asymptomatic, or what we would call pre-symptomatic, meaning they had the infection, but their symptoms hadn't started yet. So this is prevalence, right? Testing everybody, how much is out here right now at this moment. So in terms of chlamydia, again, this is something that often doesn't cause symptoms. So about 50 to 75% of the time, chlamydia infections don't cause symptoms. So instead of relying on people to come into the doctor's office to get tested because either they feel strange or somebody told them they've been exposed, we want to go out and test a whole bunch of people. And there's a study called NHANES that the federal public health agencies do, where they literally go out and just knock on people's doors and say, hello, I'm with the federal government. Can I test you for medical problems? Right? And thank goodness people say yes. And so surveillance testing, going out and testing everybody, whether they have symptoms or not, actually reveals, in terms of chlamydia, the prevalence is quite high. So, and it seems to have increased over the two different study periods that are represented here. So that we can see in the earlier study around the year 2000, about 3.4% of people in their late teens and 2.5% of people in their 20s were positive for chlamydia. In the later study, 2013 to 2016, they found higher prevalence rates, so 5.8% or 4.2%. So, right, so remember, our incidence was only 1 in 61 got diagnosed over the course of a year, but the prevalence is 1 in 25, right? So that tells us that there's a lot of chlamydia out there that is asymptomatic. Right? Let's try to find it. So a lot of asymptomatic cases, undiagnosed cases will make those numbers different from each other. So those are incidents, how many people over a period of time happen to get tested and diagnosed with something, versus prevalence. We go out in a given time chunk and see how many people test positive, whether they have symptoms or not. The final way that we look at this information is by calculating mortality rates. So what percentage of people with a certain condition die from it? Or we could look at morbidity rates. What percentage of people with a condition become disabled from it? So if we look, for example, in Dunn County, so when I did this course last year, I looked at from March 2020 until December 27, 2021, there were 9,000 or better diagnosed cases of COVID-19, so that was incidence, right, if I controlled for the population, and 58 deaths from COVID. So 58 deaths out of 9,361 cases equals a 0.6% mortality rate. Now, you might think 0.6%, that means 99.4% of people lived, so that's really good, right? Well, actually, that's quite high for all the things that we humans can get. So influenza, which is often brought forth as a comparator to COVID-19, usually has a mortality rate of about 0.1%. So this is 6 times more deadly than influenza usually is. Influenza causes about 50,000 deaths in any given year in the United States when things aren't wonky. So this is a contender. Now, what's interesting about mortality rates is that they can change over time in response to various factors. So in the case of an infectious disease, there are 2 big things that can cause a decrease in the mortality rate over time. Now, there are other factors as well, but there are 2 big ones that I want you to be aware of. One, which you probably already knew, is that the population develops immunity to the infection, either because of vaccines or prior infections, or both, actually. And we have really strong data that shows that if you have had COVID infection and you have had the vaccine, that you have really the best immunity that there is and the best protection against severe disease going forward. So immunity that develops either because of vaccines, infection, or both, as well as improved treatments. So we have been learning as quickly as we can with COVID-19. We also learn with other disease conditions. So if we look at mortality rates of breast cancer, for example, over time, now that's not an infectious disease, so immunity doesn't change, but our ability to come up with effective treatments has improved. So mortality rates can change over time as we get better at treating the condition. So to come back to the COVID example, I looked at, okay, so what about this past year? What has our mortality rate from COVID been? It was 0.6% at this time last year. And now, since December 22nd, because today's December 22nd, so in the past calendar year, we have had 5958 reported cases of COVID and 20 deaths since that time. So our mortality rate is now down to 0.3%, so it's halved. It's probably even a little bit lower than that because I think a lot of people, well, I'm pretty sure a lot of people aren't getting tested anymore. So our case number, our denominator is way lower than it should be. But we can see that we're having a lower case fatality rate because of improved immunity and improved treatments, both in this case. You can look at case fatality rates over time. So this is Our World in Data, a really interesting website where you can play around with a lot of different types of statistics. And here we're looking at case fatality rates over time between the United States in green and the United Kingdom in orange. And I pick United Kingdom because they're actually very similar to us culturally, economically, and but not entirely in terms of healthcare systems. There are a few differences, but also a lot of similarities. So what you can see is that this mortality rate is changing over time. You can also see that early in the pandemic, in that kind of first really bad winter, where we had just hospitals being overloaded, that the United Kingdom had a much higher case fatality rate than the United States did. And all the scientists are pretty in agreement that the reason is that the United States actually rolled out vaccines much earlier. So we had vaccinated at that point in time almost all of our highest risk members of the population, so older folks and people with medical conditions and occupational exposure, so people, healthcare workers at that time, because we had made contracts with the vaccine manufacturers and we had a lot of money, and so we got vaccines before they did. And so we see huge differences. But then you also see that the case fatality rate in the United States is then a lot higher than the United Kingdom's following that. And what's interesting is that although we got vaccines first in the United States, we used the vaccines less. So many more of our population chose not to get vaccinated and so did not have that benefit. You can also see toward, as we come into December now, that case fatality rates are creeping up again. And you think, well, gosh, is COVID getting more severe? Well, this is probably, again, the problem of not actually capturing all of the cases that are occurring, right? So people are doing home tests now, or they're not even testing. It doesn't get reported. So we don't have good data on the actual number of cases that are occurring. So our denominator is too low. So it makes the case fatality rate look higher than it actually truly is. Yeah, what can you do? All right, so we can also look at, so one of the things we can do is we can say, well, why don't we just look at the total number of deaths for all the people that you have, right? And so this is per million people. This is not looking at whether or not someone got diagnosed, just how many people died because of COVID over time. And again, we see that big spike in the UK in that when the, I'm sorry, we didn't see that before, when the pandemic first hit, then we see a big spike in the UK again with that huge surge that happened in the winter of 2021. And then the UK has a much lower death rate per million people than the United States for most of the interim, and now we're kind of about the same. All right, these are deaths, and this is just a reminder to look at rate. So this is that same information, but not controlled for the population. Okay, so it makes it look like our numbers are way worse, but that's just because we're a bigger country. So don't look at total numbers of deaths, look at deaths per million or per 100,000. Always look at rates. So that's identifying the problem and some of the statistics that we use to help get a handle on what's going on. The next step is etiology. So etiology means what's causing it. Etiology is cause. That's what that word means. So what is causing the problem? So in order to get clues as to what might be the potential cause of a disease or health condition, we're going to look at who is getting it and what types of characteristics do those people have in common. Where are they getting it? When are they getting it? So who, where, and when. And then we're looking for group associations. Do we find that something is more common in certain groups of people than other groups of people? Are certain groups more likely to get a condition? So historically, finding out that the chimney sweeps were getting really high rates of lung disease and cancer, and going, maybe being exposed to all that soot all the time is bad for you, right? Maybe that's actually causing the disease. Smoking, right? It was not that long ago that physicians used to smoke in the hospital as they were doing rounds with their patients, right? So, we tend to take it as a given that, of course, smoking is bad for you and causes lung disease as well as other types of disease. But it actually took a while to prove that and to figure that out. And people were very unhappy about that. We're also going to look for group associations if there's an episode of suspected food poisoning, right? So every now and then there'll be an outbreak associated with bagged salads or some other product, right? So they're looking at, okay, who got sick, who didn't, what's something that all the people that got sick have in common or were more likely to have had in their history, right? And so this looking at the distribution of disease, this might remind you of something you've already learned about, which is of course the ghost map from John Snow. So this was the founding father of epidemiology, looking at patterns of disease in a population to try to identify the cause and then identify potential solutions. So when we look at group associations, we have to be careful. We have to be wary, because sometimes just because things are correlated, they seem to go together, does not mean that it's actually causative, right? So correlation doesn't always equal causation. So it doesn't always mean it's an actual risk factor. So the fact that young adults get chlamydia much more frequently than older adults is not because young bodies are somehow more vulnerable. It's not that youth itself increases your susceptibility to chlamydia. It's that people who are in their early 20s are much more likely to be having multiple sexual partners than people in their 50s, right? So we have to be careful to not say something is causing something when in fact we just see this group association. Another example, which I think they talk about in the book, is the fact that we see rates of drowning correlate and track with rates of ice cream consumption, right? But now, does eating ice cream make it more likely that you're going to drown? No, right? But both of those things are more likely to happen during the summertime, right? So you're more likely to eat ice cream and you're more likely to go swimming. People are just swimming more, therefore we see more drownings, right? It has nothing to do with the ice cream, even though we see that association, that kind of trend that goes together. So be careful. So how are we then going to see if in fact it is a contributory cause? Is it actually causative, right? So the ice cream and the drowning example, right? Is there a cause there? If I just don't eat ice cream, am I not going to drown, right? So there are 3 requirements that we're going to need to try to satisfy to establish something as a contributory cause. The first is that cause is associated with the effect at the individual level. So while we may see at the population level that drownings and ice cream consumption go up at the same time, right? We might look at all the people who drown and find, oh, well, they didn't eat ice cream, right? So at the individual level, are they associated? The second one is about the factor of time, right? Did the cause precede the effect, right? Did it come before? Did you eat ice cream before you went swimming? In this hypothetical, ridiculous example. And does altering the cause altering the effect, right? Does avoiding ice cream prevent people from drowning? Yeah, okay. So what's interesting about this is that we don't necessarily need to understand the scientific mechanism behind how a contributory cause results in a disease or condition, but you can still identify it, right? So in the case of the cholera epidemic with John Snow, he had no idea what bacteria were, right? But he was able to identify that the contributory cause was the Broad Street pump and institute an effective recommendation and policy plan that saved lives, which is pretty darn cool. All right. Oh, look at that. So how are we going to answer those three questions, right? Those three requirements. We're going to use three different types of research studies to do that. So to answer the first question, is the cause associated with effect at the individual level? What we're going to do is a case control study. So people with the condition or disease are cases, and people without it are controls, right? So we're going to see among people who drowned versus people who didn't. Did the people who drown eat more ice cream, right? And if they did, as individuals, then maybe there is a causative contribution there, right? So, for example, if we have 10 students who got sick compared with 20 students who didn't with some type of vomiting illness, and 70% of the people who got sick ate at North Point, but only 10% of the controls ate at North Point, well, that's a potential contributory cause, right? It's more common, it's a group association that we see, it's more common in the people who got sick than it is in the people who didn't. Another example, you have 5 family members who got sunburn on a recent trip to the beach and 10 who didn't. And of the cases, the people who got sunburn, 80% of them used this new organic sunscreen, right? And 20% of them used, I don't know, Coppertone. And among the family members that didn't get sunburned, only 30% used the organic kind and 70% used Coppertone. So we see this difference, right? So this suggests that there could be a causative effect. So this may be a cause, right? But remember, there are usually multiple risk factors involved, right? Not everybody who got sick ate at North Point. That doesn't mean that there's something about the food of North Point that caused this, right? Not everybody that used the organic sunscreen got sunburn. Doesn't mean it's not a contributory cause, right? Because the presence or absence of a risk factor is not a guarantee one way or the other, right? It's not everybody who has a risk factor gets the disease and everybody who doesn't have the risk factor doesn't get the disease. It just impacts your probability, right? It's not a guarantee ever, either way. Okay, so second question, does the cause precede or come before the effect? In order to answer that question, we're going to do a cohort study. So a cohort is a group of people. We get this group of people, this cohort, and we're going to get some people who have the potential risk factor and some people who don't. And then we're going to follow them forward. Let's see, do it this way, follow them forward in time. So that's the difference between a case control where they already have the disease or not, and we're looking backward to see if the potential cause was more common in people who got disease. Cohort study, we're going to follow them forward through time. Okay, so we're going to follow them to see if they develop. So here's an example. Let's look at adults who have high cholesterol compared to low cholesterol. Follow them forward through time and see if the people with higher cholesterol are more likely to develop heart disease. And that's exactly what they did in one of the biggest, most famous studies called the Framingham Heart Study that was done in Framingham, Massachusetts. They followed practically everyone in the entire town, collected a whole bunch of information in them. It's still ongoing today, right? So you can see this was in 2002. They made a little logo, 3 generations of dedication, right? So this started back in 1948. The study is still ongoing today. We have learned so much from this cohort study. So what did they find in regard to cholesterol? Well, they found that let me get my laser pointer here. Okay, so these are people with the lowest cholesterol levels. These are people with the highest cholesterol levels. And what you can see is much higher rates of heart disease, so coronary heart disease, in both male-bodied people and female-bodied people with higher cholesterol levels. Okay, so this is a cohort study. They already had high cholesterol, and then they follow them through time. So the cause does seem to be preceding the effect. All right, question 3. This one's trickier. Does changing the cause change the effect? So in order to answer this question, we're going to do what's called a randomized controlled study. You're going to randomly assign people. You're going to say, part of you, we're going to expose you to the potential cause, and part of you, we're not going to. We're going to do this randomly so that hopefully, you know, the groups of people in each arm of the study, as it's called, are fairly equivalent to each other. Now, the problem is, if we're looking for the cause of a condition, it's often unethical to say, hey, I'm going to have you guys go do this thing that I think is going to cause a disease, and you guys, I'm going to have you not, right? That would be like me doing a study in college students and saying, okay, I want half of you to go out and have a lot of unprotected sex, and I want the other half of you to have no unprotected sex, and we'll see who gets chlamydia. So that's not ethical if I think it is likely to be a cause. So we often don't see these studies done when we're trying to identify causes or etiology of health conditions. But they are very common and exceedingly useful when we're looking for potentially effective treatments or interventions. So just to stick with the cholesterol example, let me show you a randomized controlled trial of a medication that lowers cholesterol levels. So what they did was they took a whole bunch of people who had high cholesterol levels, and half of them they randomized to get no treatment, and the other half of them they randomized to take a medication. And they followed them forward over time. In this particular study, it was for about 4 years. And they said, okay, are the people in whom we treated their cholesterol, so their cholesterol numbers went down, did they have fewer heart attacks than the people where we just left the cholesterol? And in fact, yes. Okay, so what we're seeing here is that in the control group who did not receive the medication, whose cholesterol stayed high, 7.8% of them had some type of heart disease over the course of the study, whereas in the people who took the drug that lowered their cholesterol, only 5.2% of them did. Now you might think, well, that's not a big difference, but actually that's really huge, right? So 89 versus 133. So that's a lot of people that you've saved from having a heart attack or death from heart disease. So that's really powerful. In fact, for those of you who know these statistics, we'll get to these later in the course, they had a 35% reduction in their risk of some type of heart disease. So we'll use randomized controlled trials a lot, right? Here's our control. Here's the experimental group where we did the intervention, in this case, a medication. We'll use them a lot for treatments, but we won't use them a lot to identify causes because it's often unethical to do so. Okay, so this is just a graphic from the book that looks at everything I've been talking about so far. So first we're going to find these group associations to generate our hypothesis. Be like, I think it could be this thing, right? By looking at population studies. Then we're going to do case control studies to see if in fact the individuals who got sick actually drank from the Broad Street pump. Right? So the population level study was the ghost map, and you saw that clustering near the well. Case control is then going out and interviewing people and their families and finding out, did they actually drink from this well? And then cohort studies, following people forward in time, right, allows us to see if the cause precedes or comes before the effect. And then requirement 3 is a little bit harder to do, right? It's doing those randomized controlled trials. I mean, or sometimes things are just natural experiments. So for example, in the case of COVID, some people chose to get vaccines and some people chose not to, right? It would have been unethical for us to randomize and say to some people, you're all going to get vaccinated and none of you are, but there's kind of a natural experiment that has occurred. So that's just a different way of looking at the same thing we've been talking about. So because we can't do randomized controlled trials a lot in determining etiology, there are some additional factors we can look at to try to give us evidence to support our hypothesis that this particular risk factor might be causative. So one is the strength of the relationship. So how much of a difference do we see in people who were exposed to this potential cause versus not? Is that difference small or is that difference really big? And so we're going to look at a statistic called relative risk for that, and I'll show you that in a moment. Second is dose-response relationship. So are the people who not only have versus don't have, but like have a lot of exposure, right? If you drank from the Broad Street pump several times a day versus once a week, were you more likely to get sick than people who drank from it less often? Consistency of the relationship, do we continue to see that over time? And then biologic plausibility. This means based on what we know about biology and medicine, does it make sense that this could be causing this, right? So let's just take a look at a few of those things. This is relative risk. So this is looking at strength of the relationship. And so this is some data from last year, actually this particular one, looking at case rates of COVID-19 in people who were vaccinated versus people who weren't against COVID-19. So we can see that unvaccinated people had a 5 times higher rate. So their cases per 100,000, you kind of see that here. So it's a rate. We need to make sure it's a rate. So it's adjusted for the population, was 5 times higher, right? So 67.8 out of 100,000 versus 14.2 out of 100,000. So again, it doesn't mean that everybody who got vaccinated won't get COVID, and it doesn't mean that everybody who's unvaccinated will, but we see a significant effect. There's a strong relationship, strong association here. This is also looking at death rates. Again, so death rates in this case 13 times as high, indicating that the vaccine seems to be more effective at preventing death than infection, which we now know is definitely the case. But this was early days. Okay, so just when you are thinking that these are old lectures and I'm just rehashing the old thing, I'm only rehashing part of the old things that I think are useful and don't need to be redone. But of course, we need to update the situation with COVID because things have changed a lot. But it is still here. So this slide is showing you the most recent data just from August in 2023. So Washington State just put out a report. Again, they are continuing to track these data for rates of, this particular one is hospitalizations for COVID-19, so people who end up in the hospital because of COVID, for, let's see, so let me get my laser pointer. Okay, so from January 2022, and then this is August 2023. So obviously, people are not being hospitalized at the high rates that they were back before, but people are still being hospitalized. And we can see that this red line here that's on the top is unvaccinated people, whereas the yellow and the blue are people who have received vaccines and or their booster shots. So again, we can see that although largely because people have developed natural immunity, right? Because pretty much everyone has been infected at least once at this point. Not everybody, but pretty much everybody. So the difference between vaccinated and unvaccinated people, that strength of relationship is smaller, but it is still there. And what's interesting is it's still the hospitalization rate, and this particular graph is looking at 65-year-olds. And then I should also just illustrate again, this is per 100,000 in the population. So again, we're looking at rates, not total numbers, so it's controlled for the populations. I should also clarify, because I didn't on the prior slides, that when they're looking at unvaccinated people and they're looking at rates, they're looking at out of the total number of unvaccinated people. And then when they look at vaccinated people, they look at out of the total number of vaccinated people. So, so they're doing their data properly, which is great. But so we can see this 2 times higher risk of hospitalization for unvaccinated folks that still persists. And it's a lot smaller than it was before, that strength of association, but to be twice as likely is still a big deal. So that's kind of important. The other thing that I found in the Washington State data, which was really interesting, is that they also looked by age group. So again, I just couldn't resist the opportunity to show how health impacts are different at different stages of the lifespan. And so again, here, this is also looking at hospitalization rates, which is great because if you're hospitalized, then we know you're tested for COVID-19, so we don't have to worry about underreporting and all that kind of stuff. So hospitalizations are a nice number to look at. But again, we can see significant differences. So down here is ages 65 plus, right? Those are our folks that are at highest risk for hospitalization and death from COVID-19, much like for influenza. And then we see ages 35 to 64 and 12 to 34. So you can still see that strength of association, that vaccination is associated with significant protection against hospitalization versus being unvaccinated. But you can also see that age is a much stronger factor here, right? So an unvaccinated 40-year-old is still much less likely to be hospitalized for COVID-19 than a vaccinated 70-year-old. And them's just the breaks, right? That's just how things happen. All right, so I just wanted to show you some recent data. I am paying attention. Okay, so this again is that graphic that you saw before. So those are those 3 requirements. We talked about how sometimes number 3 is hard to do when establishing causes, but we can look for contributory cause or efficacy. We can look for other supportive indicators, right? Like consistency of the evidence, strength of the evidence, biologic plausibility. Those things can all help. So what I want to reinforce, and I've mentioned this already, is that contributory cause is not a guarantee one way or another. It does not determine whether you will get the condition or not, right? It just increases or decreases the likelihood that you will, right? So it stacks the odds one way or another, right? Not everybody who's unvaccinated gets COVID or gets hospitalized or dies from it, and vaccinated people still get COVID, right? So having that contributory cause just increases your odds, increases the chances that the condition will occur. It's not a guarantee. There are so many other factors at play. Humans are really complicated, right? So not everybody who smokes gets lung cancer, right? Not everybody who has unprotected sex gets chlamydia. And so, right, it's not a guarantee. And not everybody who gets cancer, it's not because they didn't eat right or something, right? There's a lot of other things. So far we've talked about problem and etiology. In part 2, we're going to talk about recommendations, implementation, and evaluation.